understanding of angiograms, because the diagnosis, therapeutic modalities of lot of congenital heart diseases depends on the angiographic evaluation. So let us see how we can justify in the next 30-40 minutes or so. So, who are these giants, legends? Can anybody tell? Do you know who are these giants? History is very important. See, look at the history. Last 1 decade back, you are using land phones. Now you are using a cell phone. So, earlier days, people were not having any clues to know the anatomy. They were purely dependent on the morphology based on the autopsy. So Werner Frossman, Andrew Cournot, and Richard, these are the three legends in the cardiac physiology. They described angiogram first in 1940s. These three people got a Nobel Prize, awarded Nobel Prize. So you can't forget Werner Frossman and Andrew Cournot. There is a catheter after his name called as a Cournot catheter, that is an end hole catheter essentially used for the right heart catheterization. So the cardiac catheterization lab came into picture in the early 1950s. Initially, it used to be a analog recorded in the tape. Now, tape became historical, like our camera, where we used to take film. Now, digital cameras totally changed, revolutionized the image quality. That's why you guys don't even aware that earlier we were recording in the films. Even during my DM days, that is in late 90s, we got the opportunity to see the videos as well as the angio film. So, however, the technology now changed a lot of things. So, if you look at here, this is the table, the power source, C-arm, this is X-ray source called gantry, and then video camera or image intensifier, which takes the picture from the structures, and the output will be given to the analog to digital converter, and then you will see the display here in the monitor. So that is what the cardiac catheterization lab functions. So you have variety of vendors who manufacture, but in congenital heart disease and structural heart defects, to reduce the radiation, to get the proper pictures, you need to have a biplane modality of imaging quality. You can see here, this is the frontal plane, this is the lateral plane, and you can use both planes in different angulations, LAO, RAO, AP, lateral, based on the requirement of that particular congenital heart disease. This is very important to have an understanding about the source imaging distance and then the reference point of the interventional point. So gantry is here and your image intensifier is here, and keeping an optimal distance as low as possible generally avoids scattering of the radiation, so that you will not get irradiated unnecessarily. So safety of radiation is very important. You all should maintain the a safety precaution, either reducing the collimation and keeping the lead shields, and then keeping the proper distance from the image source to the image intensifier, the radiation source to the image intensifier, to get the optimal image. So if you look at the cardiac structure, heart is in the thorax like this, which is in oblique directions, whereas superior vena cava ascending aorta you can see which is straight in frontal plane. That means in a coronal section itself can show the aorta and superior vena cava relationship. Whereas if you see the ventricles and the lie of the heart, which is actually, if you look at it here, which is going to be from 11 o'clock to the 5 o'clock position. So, based on this, we need to think how we are going to project or image the various structures of the heart. And now you can see this is what the heart lies. If you are going to project the X-ray beam and take the image intensifier is nothing but your vision or your eyes. Always think that image intensifier is your eyes. So if you project from lateral LAO view, you will be able to profile the cardiac structures decently, the interventricular septum and interatrial septum. Whereas if you project from the RAO 40 degrees, you are going to project the atrioventricular groove and the crux of the heart. So, basic understanding of the anterior posterior projection and lateral projections are very, very crucial to have the proper image quality, proper images of various structures either in the normal or normal heart. So if you look at here, this is AP projection, superior vena cava, a part of the right atrium, part of the right ventricle, and the outflow tract. Whereas in the lateral view, you can see the right ventricular outflow tract, pulmonary artery, aorta will be like this. So based on that, you should have understanding of how you are going to actually project or image various structures. Hello? Hello, am I audible?
Yeah, you're audible, Dr. Nageswara.
Okay. Thank you, ma'am. Thank you.
Yeah, sure.
So now you can see the cardiac structures in the frontal plane. You have an oblique here, and if you see in the sagittal, this is nothing but a coronal plane. Sagittal plane, you have again oblique and axial cut. Again, you can see that it is a foreshortened. So none of the views, actually if you take either coronal, sagittal or axial, you are going to get a proper picture like what you see in case of CT scan. Whereas adding a cranial or caudal tilt actually will profile the interventricular septum, interatrial septum, outflow tract and ventricular anatomy much better. So we all should have an understanding of the image intensifier and then gantry location when you are profiling the cardiac structure. So based on that, you have a frontal, that is AP projection, LAO projection, lateral projection, RAO projection, right lateral projection and RPO projection. So variety of views if you club with the caudal or cranial angulations, so you will get and you will be able to position it. So two orthogonal projections are very important whenever you have a complex anatomy, when you are not able to define. Sometimes even ductus arteriosus is a simple structure, you may not be able to see in lateral projection, then you have to go to orthogonal projection of RAO 40 degrees to profile the duct anatomy. Similarly, the left ventricular angiogram, LAO and RAO view will give some kind of good information if you club both the things. So in a situs solitus situation, if you want to project interatrial septum, you will have a LAO here, RAO here, whereas similar RAO, you will be able to see the interventricular septum in case of situs inversus totalis. Similarly, a LAO view in case of situs solitus will give the proper interventricular septum, whereas in case of a situs inversus, you will see what exactly we are showing in the situs solitus in RAO view. So earlier days, people used to see arm movement used to be very much restricted, so that I think historically even I am not aware that they used to actually till the children. So this is, you can see that instead of AP cranial view, they used to keep the position of the child a sitting up view. This is called a sitting up view to profile the right ventricular outflow tract and pulmonary artery. So this is equivalent of elbow view and of the lateral view. People used to actually tilt the patients and then used to get the angiograms. Now, however, with the availability of the CM, you can even identify the complex coronary anatomy in a D-TGA, where you want to do the AP caudal view. You can see this is AP caudal view to propel the coronary artery anatomy. With the availability of the CM, you will be able to propel much better. So a CM movement can be AP, lateral, LAO, and AP cranial here, and AP caudal, and RAO view. Various views you can obtain. Complex anatomies, sometimes you may have to use multiple views or rotational angiograms. So a word about the angiomat. A lot of people, they do very irrationally using hand injections, end-hole catheters. All those things are not advisable. When you are doing a proper angiogram, you should do angiogram. The volumes will vary from the type of the angiogram. Either it is 0.5 ml to 2 ml per kilogram. If you have a large shunt like a large VST, you may end up giving 1.5 to 2 ml even. And the flows depend on the structures. If you have a low flow situation, like if you are giving a Glen or inferior vena cava for TCBC, you may give 8 ml per second. And if you want to give high flow ascending aortic structure where AP window or any aneurysms, you may even go up to 20 ml per second in an adult. Whereas PSI pounds pressure of this per square inch, 100 PSI equal to 6.8 bar atmosphere. We can go anywhere between 500 PSI to 1200 PSI. I generally prefer to use 700 to 900 PSI in ventricular angiogram. Sometimes we may have to put a delay because as soon as you press the angio, injector should not deliver the contrast. So you tend to put a delay of 0.1 to 0.2 seconds. That means angiogram will be delivered after that. Angiogram catheters are very important in delivering the ventricles. So you can see how the contrast is being delivered here with NIH catheter here. Sometimes I use NIH catheter, pigtail catheter, and Burman angio catheter. NIH catheter, multiple side holes, no end hole, so that the contrast delivery will be and force will be reduced, and since there is no end hole, it is not going to traumatize the ventricular septum here. However, if you give high pressure, it may cause some kind of staining and injury to the right ventricular tuberculations, right ventricular free-wall. Whereas the pigtail catheter essentially being given delivered in case of left ventricle and aorta and aortic branches and descending aorta. So here you have multiple side holes and end holes, and dispersion of pressure is very fast, so that you have opacification and good angiograms. Whereas Burman angiogram catheter is being commonly used in case of right heart studies, right ventricular angiogram, pulmonary artery angiograms. So to have the understanding of the interventricular septum, if you look at the frontal plane that is in AP projection, your interventricular septum is foreshortened and which is oblique. And if you make a cranial tilt, you can see that foreshortening is removed and interventricular septum became more elongated here. So that kind of anatomy imagination is very vital. If you have a CTGA, already it is a visa cardia is there. So you just need to do in AP cranial projection. So a ventricular septal defect based on its location, if you have a ventricular septal defect here somewhere which is inlet or postmuscular VST, here you can see if it is here, that is between 9 o'clock to 11 o'clock, it's going to be perimembranous and then little bit of outflow extension, and then you can see pure supracrystal or subpulmonic VST. So if you have these kind of VSTs, based on that, you need to actually select the view. So here you can see the frontal plane. This is LAO, this is RAO, this is lateral. So frontal plane, which is the foreshortened, LAO, which is LAO cranial, which is elongated nicely, whereas in lateral, which is elongated, but there is a overlapping here. You don't see any right ventricle, so you may not be able to see all VSTs. Whereas if you look at carefully here, this is the pulmonary wall, this is outflow. So whatever outflow VSTs, you will be able to define properly in either lateral view or RAO view. So here you can see that the mid-ventricular or membranous VSTs all nicely in the LAO cranial. So a standard LAO cranial is nothing but you are calling it as a long axis view. Whereas you will have a lot of foreshortening and overlap in case of AP projection, and it is no longer recommended and we don't do it there. So interventricular septum anatomy is very crucial to understand, whereas subpulmonic, infundibular, perimembranous, anterior trabecular, midmuscular, all these locations, based on that we are going to do the angiogram. So this particular slide is very, very important for all of you, and the projections, how it is going to be called as a conventional RAO means it is a 40 degrees RAO. So these are the terminologies, whereas shallow LAO means it is from 0 degrees to 30 degrees, straight LAO is 30 to 60 degrees, whereas steep LAO is beyond 60 even to the lateral and left lateral, and you have cranial tilted RAO, cranial tilted frontal view. That is what we called as sitting up view in a chair, where you see the right ventricular outflow tract and MPA and anatomy, whereas cranially tilted shallow LAO view, cranially tilted mid LAO. So all variety of views you should know before you start the angiograms. So let us go to the clinical examples. So now you see the systemic veins, where the superior vena cava, innominate vein, inferior vena cava, azygos this side, and hemiazygos vein. So you have normally a right SVC, but in congenital heart disease, there may be LSVC, left SVC, or bilateral SVC, or bridging vein, or only LSVC. So let us see a couple of examples here. So this is what a normal superior vena cava. If you see carefully that there is a superior vena cava going to jugular, and there is a little bit of contrast going to the innominate, and then right atrium is filling. Whereas here you can see superior vena cava is small and which is obstructive, and lot of veno-venous collaterals are formed here. So you expect in these cases there is a left cava. You can see that the left cava is faintly filling through the veno-venous collaterals on the other side here. So this is very important to understand that kind of anatomy. So in a dextrocardia you can see that here beautifully you can see the innominate vein, and then you can see the superior vena cava. Whereas if you look at the catheter which is coming from the left side, normally the catheter inferior vena cava is on the right side, and aorta, descending aorta, is on the left side here, which is crossing the atrium and then going. So that means you need to suspect that whether this patient is actually having a situs inversus and then only right SVC. So here you can see a condition where left superior vena cava which is draining to the corner sinus here. We are not demonstrating the right SVC, but the catheter is going from the inferior vena cava, corner sinus, and then to the left superior vena cava there. So similar example, the left inferior vena cava crossing the spine and then going to the left superior vena cava. Here you have an example of retroaortic innominate vein. This is the innominate vein, and you can see the pigtail catheter here. This is called as retroaortic innominate vein. So this is most popular. You can see the H anomaly here. That means two SVCs are communicating each other. This is very important to know, because sometimes in case of bilateral bidirectional glen, you have unroofed corner sinus, then you may have to ligate the LSVC if you have a proper bridging vein. Or if you have a bridging vein like that, surgeon may do a bidirectional bilateral glen without cardiopulmonary bypass using one side of the superior vena cava as a vent. So it's all possible. It is very important to know the anatomy very well. So you can see here a right arm injection here, which is actually showing a superior vena cava is filling into the pulmonary artery, suggestive of it is a bidirectional gland. Whereas here you can see that the right jugular injection showing left superior vena cava is communicating the pulmonary artery. So surgery, you can see the surgery is left bidirectional gland surgery here. So what is happening here? You can see that there is a one SVC here, the other SVC injection is given, suggestive of it is a bilateral bidirectional gland surgery. So the injection is being made in the left superior vena cava from the right superior vena cava through the gland shunt through the pulmonary artery here, suggestive of a functioning left-sided bidirectional gland. So coming to the inferior vena cava, you can see the inferior vena cava, renal veins here and hepatic veins are draining to the inferior vena cava and subsequently to the right atrium. So a normal inferior vena cava injection shows that in the mid inferior vena cava reflects into the renal veins, reflects into the hepatic veins. You have three hepatic veins, left, right, anterior, posterior here, which is draining into the right atrium here. So what is this anomaly? Can anybody tell? Can anybody tell what is this? What is happening? So there is a physiological interrupted IVC. It is not actually pathological. It is a physiological. There is a partial anomalous pulmonary venous written that is called as scimitar vein is draining here, leading to the physiological interruption and leading to the IVC continuing as draining into multiple spinal veno-venous collaterals and subsequently to the ajagas vein. So you can call it as interrupted IVC. That is very good answer from your side. And here you can see that interrupted IVC through the hemi-ajagas and then going into the atrium there. So anybody, what is this? What is this shunt called as? What is this surgery? What was the surgery done to this child? What was this surgery? Wonderful. So this is in a IVC interruption where IVC continuing as a hemiagus into the superior vena cava, it is connected to the pulmonary artery. So this is nothing but a Kawashima operation. In this, almost all systemic veins except hepatic veins are routed to the pulmonary artery. So systemic veins including superior vena cava and inferior vena cava routed to the pulmonary artery, but hepatic veins are not routed to the pulmonary artery. Hence, there is a tendency that they may develop a pulmonary AV fistulas in the long term. Here you can see the classical example of a superior vena cava here and inferior vena cava here, and this is nothing but extracardiac TCPC here. So I'll just briefly touch the various anatomies. That is what actually I am interested. A right atrium, if you look at here, right atrium, which is a triangle shaped here, and this is the right atrial appendage, superior vena cava and inferior vena cava in line of continuity here. So here in a post-operative rerouting of the superior vena cava, which was running earlier to the left atrium, you can see that SVC and right atrium here, and right atrium, and then opening to the right ventricle through the tricuspid valve, what you are seeing the schematic diagram here, and then to the main pulmonary artery. So generally we don't do right atrial angiograms unless there are some important issues where the juxtaposed atrial appendages. Sometimes lateral tunnel fontan is not possible if you have a juxtaposed atrial appendages. That means both atria on one side of the arterial pedicle, that is pulmonary artery and aorta. Here you can see the classical left juxtaposition of atrial appendages. That means right atrial appendage is on the left side here. And also operations like sending and mustard also going to be difficult. Surgeon should aware that there is a juxtaposed atrial appendage. Similarly, from the interventional point of view, if you want to put a pacing lead in the atrial appendage is going to be an issue. And or balloon atrial septostomy, you should aware that your balloon should not go to the atrial appendage thinking that you are crossing the interatrial communication. So this is a couple of examples. A juxtaposed atrial appendage you can see in a tricuspid atresia situation, right atrial appendage is on the left side here. So when you see juxtaposed atrial appendages, you probably should think about the complex congenital heart diseases commonly associated with a tricuspid atresia, complex transpositions, anatomical malpositions, single ventricle, and double outlet right ventricle with remote VST, L malposition great vessel, that kind of a subset constellation of findings are generally seen in those conditions. So it has got some importance. So whenever there is a juxtaposed atrial appendage, whenever you are doing a cardiac catheterization, I feel it may be worth doing in AP projection, and then probably you can demonstrate from the morphological point of view, and also surgeon will aware that this is going to be useful. Whereas the pulmonary veins profile, generally we do in anteroposterior projection or LAO projection and RAO projection based on the pulmonary vein which is specifically involved either stenosis or anomalously draining. So all pulmonary veins posteriorly they drain to the left atrium, and you look at this levogram of this AP projection of the pulmonary artery injection, which is showing all pulmonary veins. You can see the left lower, left upper, right lower, right upper pulmonary veins nicely draining to the left atrium. So you will be in a position to profile the pulmonary veins by levogram if you do a pulmonary artery angiogram, unless you have a foramen ovale communication where you can cross the foramen ovale and selectively you can do the angiograms with multi-purpose catheters. Generally, you don't give pressure injections in the pulmonary vein because reflexively it can go into the pulmonary vein and the child will become unstable during the angiogram. So this is just want to show you how the left atrial appendage will look like. This is the left atrial appendage angiogram is a part of the left atrium. So left atrium is formed by pulmonary veins confluence and then left atrial body and left atrial appendage. Now left atrial appendage has got a lot of importance. You all know that in case of atrial fibrillation and CHAD score is high, they are going to put a device here to exclude the left atrial appendage to prevent the thromboembolic phenomenon. So what is this? Can anybody tell this? What is this? The left pulmonary artery injection here. What are you seeing? And what are you seeing on the other side? So left vertical vein. So when you give a selective injection here, you may see left vertical vein. When you see a selective right lower pulmonary artery injection, you can see the scimitar vein here, which is draining to the inferior vena cava. So this is a persistent of vertical vein followed by surgery here. You can see the persistent of vertical vein here, very big vertical vein. This is the supracardiac DAP where I am sorry for that. A pulmonary artery injection, you can see that the pulmonary veins which is forming the CPV, then vertical vein, then innominate vein, and then to the superior vena cava bag. Whereas here, followed by surgery, a persistent of left vertical vein being closed using a device from the left jugular venous approach. Just to show you the examples of how it will look like. So we have 15 more minutes time to deal with. So we are going to talk about the right ventricle and left ventricle today. So if you look at the right ventricle here, this is the ventricular surface of the right ventricle here. You can see the right atrium, right atrial appendage, AV groove here, tricuspid wall, right ventricular inflow, body, outflow, and pulmonary artery. So AP view, which is showing most of the structures in the right ventricle side. So it is good to think that AP view may show right ventricle to some extent, whereas here because of the angulation of the right ventricular outflow tract towards the MPA, you may not be able to profile this. Hence, we go cranial angulation here, cranial tilting. So if you really want to profile main pulmonary artery, right ventricular outflow tract, you need to have a cranial angulation to see the bifurcation as well as the outflow tract. So essentially, right ventricle is a complex structure which has got right ventricular inflow, tricuspid valve here, and right ventricular apex and body, and there is a moderator band, there is a septal band here, parietal band, and pulmonary valve. So in case of right ventricular outflow tract obstructions like a tetralogy fellow, you have severe infundibular stenosis and hypertrophy that is essentially due to septal band and parietal band hypertrophy. So you will see angiographically these kind of structures if you properly delineate the anatomy. So this is a right ventricular angiogram in LEO view, just to show you how right ventricle will look like in LEO view here. So this is the line of the interventricular septum LEO cranial. You can see nicely seen right ventricle side how coarsely trabeculated you can see here. This is the tricuspid valve and beautifully triangle shaped right ventricle seen here very nicely. Whereas here in case of AP view, this is a hypoplastic right ventricle. So since it's a hypoplastic right ventricle, you can see that the tricuspid valve is hypoplasia, body is not well developed, whereas right ventricular outflow tract is seen. So right ventricular influent body probably better delineated in case of in AP view. So here you can see a shallow cranial view, a shallow LEO cranial view. You can see that right ventricular outflow tract and body is fairly delineated, and what you are seeing a structure, hyperlucent structure here is nothing but the infundibulum. This is nothing but a septal band here. So in case of tetralogy fellow, you can have a severe infundibular stenosis. You can see that band very nicely seen here, and I will show you much more interesting. So here you can see that infundibular stenosis is very interestingly seen. So this is again clamping of both. This is a septal band and parietal band, both are seen, and coarsely trabeculated right ventricle. Right ventricle, this is AP cranial projection which is seen here. So here shallow LEO cranial to show that elongation of the right ventricular outflow tract as well as the main pulmonary artery. So this is the pulmonary valve. So elongation of the right ventricular outflow tract is better seen here. Whereas if you want to see a pulmonary annulus and pulmonary valve for the pulmonary valvotomy, it is better to do in lateral projection. Here you can see that lateral projection shows that a right ventricle which is seen. Again, this is the tricuspid valve here, right ventricular inflow, body, outflow tract. You can see very nicely these all infundibulum. You don't see the normal infundibular structures in a normal case, and then you can see the pulmonary valve, main pulmonary artery, and bifurcation you won't be able to see because there is a significant overlap will be there. So this pulmonary annulus can be better measured, better delineated in lateral projection for the balloon pulmonary valvotomy. You can see this particular view. Whereas a pulmonary artery bifurcation, you can see here either steep cranial AP or shallow LEO steep cranial may be useful to separate the main pulmonary artery bifurcation so that you can delineate the ostium of the either RPA and LPA. So here the injection is given in the main pulmonary artery, a Berman catheter, a pulmonary annulus is small here, hypoplastic, and valve is stenosed, supravalvular stenosis is there, and bifurcation is nicely seen. Here again you can see another picture which is delineating the left pulmonary artery because of the LEO cranial, and right pulmonary artery some kind of overlap is seen, and the pulmonary valve is seen which is doming. This is subpulmonary injection is given in this patient. And bilateral branch PA stenosis sometimes difficult, and you can see the duct hump here in case of syndromic children or rubella syndrome or Williams syndrome. You will see this kind of duct hump where the ductus arteriosus is closest from the aorta, and this is nothing but a pulmonary ductus ampulla in the pulmonary artery side. This is a case of bilateral peripheral pulmonary artery stenosis where we can't really profile everything here. So you have to go individual pulmonary artery. First you do 2 orthogonal views to find out the vessels. So this is a ductus arteriosus injection in a complex cyanotic congenital heart disease, duct dependent circulation, and you can see the bifurcation stenosis which is present both the LP and the right pulmonary artery. So coming to the anatomy of the left ventricle, again you have left atrium, left atrial, left ventricular inflow, apex and outflow. You can see the outflow, aortic wall and aorta is seen here. So now you understood that to have the left ventricular angiogram, there are 2 views which are important, either LAO view or RAO view are going to be important. So this is just to show you in case of AP how it looks like and lateral how it looks like. Going back to our original diagram, if you have a steep LAO, that is LAO, standard LAO, that is long axis LAO, anywhere between 50 to 60 degrees and a cranial tilt, you will be able to propel the interventricular septum. Whereas if you go RAO, you will be able to propel the AV groove. So let us see how we are going to put these views to propel the interventricular septum. So to get the interventricular septum, you should have a cranial tilt. If you don't have a cranial tilt, there will be foreshortening. Here you see cranial tilt is given, the interventricular septum is elongated. So here you can see in case of RAO injection, again interventricular septum, it looks, left ventricle looks like as if there is a tetralogy fellow upturning of apex. So a standard LAO cranial that is called as the long axis view is very important to propel the membranous septum, mid septum, even including the apical septum. So this is just a fundamental issue. I'll just tell you that in AP view, you have a spine which is in the midline here. So if you do ventricular injection, you will get a foreshortened interventricular septum and you will get this kind of left ventricle. This is a shallow LAO. LAO is between 30 to 45 degrees, and you can see the left ventricle spine, you can see that which is coming towards the lateral, and still it is going cutting the heart border here, heart, mid of the heart. So you will get a ventricle which is profiling the most of the AV groove, and then you can see that interventricular septum. This is the view which is going to be useful for the inlet and postmuscular VSTs. This is going to be hepatoclavicular, I am going to tell you that. Whereas if you go to the long axis cut here, you can see the interventricular septum, membranous septum is being propelled here. If you go lateral, then only anterior part of that is the outflow ventricular septal, you can see the you probably will see the supracranial VSTs and outflow VSTs in. So left ventricular injection, here you can see how it is being done in case of RAO projection. There is a inlet here, and lateral injection, how it looks like. What I have shown you the schematic diagram. There is the mitral valve, inflow, the body, and then outflow here. So interventricular septum in LAO cranial, you can see well profiled, well delineated here, and a large VSTs can be seen, a malaligned VST in standard LAO position. I am going to show you one important diagram now. So this is again to tell you spine midline, spine off of the cardiac silhouette, spine more than 2/3 of the silhouette, and outside the cardiac silhouette. So spine midline, you won't be able to see any VSTs. Spine off of the cardiac silhouette, that is called as inlet postmuscular VSTs. Hepatoclavicular view you can get, that is the steep cranial in a shallow LAO. Shallow LAO means around 40 degrees LAO and 35 degrees cranial angulation. Whereas spine more than 2/3 if you see, that is long axis cut, long axis view, and outside the spine, that is the lateral or equivalent of the RAO, you will see the outflow VST. So again, I am going to overlap this. You can see that picture a mid-muscular VST is a long axis cut, anteromuscular VST is steep LAO, and posterior muscular VST you will see in the inlet posterior muscular you will see in case of a hepatocalcular view. Whereas subpulmonic VST and outflow VST, either you can profile in lateral view or right oblique view. So you can see these pictures, then you will understand much better. So this is a membranous post-operative residual membranous VST. You can see better delineated by long axis, that is LAO 60 and cranial 20 angulation here. Whereas outflow VSTs, the VSTs, muscular VSTs which is in the anterior location, anterior muscular location, you can see here, which is seen better in RAO view here. Whereas here you can see left lateral position, it's a supracrystal VST, subpulmonic VST being closed by a device called PFM coil. One of my friend, colleague, Dr. Tin came to India and he performed this kind of procedure in our hospital. So this is a supracrystal subpulmonic VST. We don't do regularly this and this kind of procedure is being done in case of in Vietnam and other countries. So here you can see RAO view. This is the anteromuscular VST. I'm sorry, this is situs inversus totalis with outflow VST here, and the right lateral view. This is left lateral view. This is RAO view. RAO view you can see here anteromuscular VST, which is being profiled here very nicely, and this is a muscular VST, which is a postmuscular VST, is being profiled in case of in a child with 45 degrees LAO here, and this is again you can see the VST at a moderate level being profiled in by the long axis view here. So various views are very, very important to understand the locations and to delineate the morphology. So I think I'll just give you a quiz here, aorta, and then we'll stop. What is this? What is the importance of this second angiogram? No, I thought I'll cover most, but we lost 15 minutes, so we'll be able to do. What is the importance of this particular angiogram? Anybody? Can you hear me or you can't hear? Okay, there is no intracardiac defect. It is only right aortic arch. So when you see right aortic arch, you have to see neck vessel pattern. If the neck vessels are good, all branching pattern, if it is a mirror image, then you can rule out the vascular ring. Otherwise, there will be, I'll show you that. What is this anomaly? The second angiogram and first angiogram?
Yeah,
what is the first angiogram? What is the first angiogram? So, yeah, no. So here what I want to tell you is, any pathology in the ascending aorta, the best view is, ascending aorta pathology can be delineated best in what view? AP view. A for apple, A for ascending aorta. So ascending aorta for AP view. So here you can see that the pulmonary artery is arising from the aorta. It is not AP window. AP window will have two semilinear views. So this is a type 1 truncus arteriosus. You can see that pulmonary artery is arising from the one single great vein. So here you can see that this is the right pulmonary artery is arising from the ascending aorta in a right aortic artery situation. This is very interesting, a hemitruncus with the right aortic arch. I will show you one more example. So what is this? What is this? So this is again hemitruncus in a left aortic arch situation, but here left pulmonary artery is arising from the ascending aorta. So because it's a left pulmonary artery arising from the ascending aorta, we could not do in the AP view. You can see that it is being done in the LAO view. And here you can see a right aortic arch. Here right aortic arch in a complex synovitic congenital arteries. You still have a left PDA that is coming from the brachiocephalic trunk, because in right aortic arch mirror image branching will be there. There is a innominate artery and ductus arteriosus is arising from the base of the innominate artery and supplying the left pulmonary artery. So here left pulmonary artery is disconnected, being palliated by the intervention here with a stent and then subsequently undergone surgery. So please answer this. What is this and what is this? So ascending aortic pathology in AP view. You can see here this is AP view. Again this is AP view. Absolutely correct. This is supravalvular aortic stenosis. You can see that very much constriction here above the sinotubular junction. And very important thing is, look at the coronary artery. The left main coronary artery is just exactly coming from the very closely to the stenosis. So sometimes it's involved, even you see the left main coronary artery stenosis. So supravalvular aortic stenosis may be associated with the Williams syndrome and non-Williams syndrome. What is this other side? Now you tell me what is this. So there is one semilunar wall and another semilunar wall. So this is the communication. This is the communication between the ascending aorta to PA. This is AP window. So how do you classify AP window? What is the classification of AP window? Yes, very good. Morris classification. So type 1, proximal, distal and mixed. So it is a proximal here, ascending aorta to MPA communication. So we may stop with this angiogram. Somebody can read this, the angiogram here. Please read this angiogram. Absolutely correct. There is a severe coarctation of aorta and the subclavian artery is arising from the coarctation of aorta. This is called as aberrant right subclavian artery in a left aortic arch situation. Very good answer. Very good answer. So tell me what is this diagnosis so that at least I can complete the ascending aorta and arches. What is this? This is congenital pathology. Your right hand side is acquired pathology. So here what you are seeing is, no, the angiogram still picture is Takay's arthritis. You can see the multiple beaded appearance with various levels of stenosis here. Whereas here you are seeing in thoracic and abdominal aorta, multiple collaterals are seen. You can see multiple collaterals are feeding the pulmonary artery with various degrees of stenosis, dilatations are present. So I think we'll stop here because we cannot go beyond this. Thank you very much. Probably if I get opportunity, I'll show you more angiograms and more interactive sessions, because today ma'am instructed me to give a basic overview of the angiogram. I'm sorry for that, because of the initial delay I could not do